Good evening, everyone. I'm Kritika Monga from the Marketing Department, Elsevier, India. Today, me and my colleague Priyanka will moderate the session. We would like to welcome you all for joining us today. Before moving forward, I would like to lay down some rules for smooth execution of this webinar. You will be on mute throughout the session. You are requested to please post your questions in the Q&A tab seen at the bottom of your screen. Also, from time to time, some polling questions will prompt on your screen. We request you to please answer those to make the session interactive. Now, I would like to take the opportunity to introduce our speaker for the day, Dr. Richard Hobson. Dr. Richard qualified in medicine in 1988 in London. He trained in various specialty and generalist posts, including working as a medical officer in Antarctica. He then pursued training in medical microbiology, gaining MRCP in 1996 and Fellowship of the Royal College of Pathologists in 1999. He was appointed as a senior lecturer and consultant microbiologist in Leeds in 2002, where he pursued a special interest in fungal infection. In 2003, he completed a PhD in molecular biology, and he then developed an interest in legal medicine, gaining a master's degree in medical law in 2015. In 2015, he moved from Leeds to Harrogate District Hospital, where he continues to practice as a clinical microbiologist as well as working part time for the UK General Medical Council, where he is involved in investigating doctors' fitness to practice. His research publications reflect his varied interests and career. He has published on viral, bacterial, and fungal infections. He has been involved with Davidson's Principles and Practice of Medicine since 2007, firstly as a chapter author, more recently as an editor. Thank you so much, Dr. Richard, for joining us today. Now I would like to hand over the session to you. Thank you so much.
Okay, well, thank you very much for that introduction. It's much appreciated. I hope the technology is all working and that you can all hear me. I was asked by Elsevier to provide a teaching session, and I chose a rather broad topic, which is the principles of infection, antibiotic treatment, and antibiotic resistance. Now, clearly, that's a huge topic, and I wouldn't dream of trying to cover all that in depth in a short session like this. So, what I'm aiming to do in this next 45 minutes or an hour or so are to review some of the principles of diagnosis in patients with possible infections, review some of the principles of management of infection, and principles which are specific to infection rather than other types of clinical presentation, discuss the principles of selection and refinement of antimicrobial therapy, and to discuss a few of the ways in which antibiotic resistance influences the management of infected patients, and in a tiny way to contribute to India's National Action Plan for Antimicrobial Resistance. I should say at this stage that the practice of infection where I work in North Yorkshire and West Yorkshire is probably very different to the practice of infection in various parts of India, where I understand most of the audience work. And you may look at this and think that some of the antibiotics, or all of the antibiotics that we use in our practice may not be appropriate for your own practice. And I think one of the most important principles of antimicrobial therapy is that it is in fact very, very regional and depends entirely on local epidemiology. So if you see me talking about treating patients with cefuroxime and gentamicin, and you know that in your own area those antibiotics there would rarely be organisms that would be covered by those antibiotics. What you have to remember is that this talk is about principles of investigation and treatment rather than the specifics. The other thing I should say is that because I'm covering the subject of resistance, I think most of what I'm talking about here is about antibiotics and bacterial infections rather than antimicrobials, which of course is a much wider topic. So the little bit about the India's National Antimicrobial Resistance Action Plan, I thought I'd take this opportunity just to bring this to your attention. This was set up by the Indian government in 2017. And there's a number of strategic priorities. Of course, it was set up to reflect the fact that antibiotic resistance is an increasing problem in India. And there are 6 strategic priorities, and I feel I can contribute in this talk to 2 of them in a little way. Number 1 was improve awareness and understanding of antimicrobial resistance through effective communication, education, and training. And number 2 is optimize the use of antimicrobial agents in all sectors. And I think most of what I'm talking about here is about optimizing the use of antimicrobial agents. So I'm going to start by talking about the diagnosis of infection. And of course, my understanding is that most of the audience are final year medical students, although I'm sure there are faculty as well, and perhaps some more junior people. And so, of course, everyone is familiar with the fact that diagnosis of any infection, of any condition, is made by a combination of history, clinical examination, and investigations. And it's normally done in that order. And I think that also most people would accept that most diagnosis is based on history. The clinical examination contributes and investigations contribute, but history is a major part of diagnosis. So in infection, or patients who might have an infection, because of course you don't know when you first see a patient, the history is aimed at establishing 2 things. First of all, the presence of an infection, and secondly, the site of an infection. That's quite an important point. To some extent, it's aimed at establishing the severity of infection as well, although that comes more in examining a patient. And the history, of course, is the starting point in creating what you might describe as a ranked list of possible diagnoses, with the most likely one at the top. And that, of course, is called the differential diagnosis list. The history largely determines the nature and scope of the physical examination. For example, if a patient presents with a history of fever, rigors, and abdominal pain, then there are many possibilities as to the cause of that: intra-abdominal pathology, renal tract pathology, extraperitoneal psoas abscess, back infections, even pneumonia can cause abdominal pain and fever. And of course, in going through the history, you start to narrow down on which it's most likely to be, and that informs your physical examination. Now, what I wanted to concentrate on for the purposes of this talk was 3 areas of the history which are very important in patients who are considered likely to have infection, but which, unfortunately, in my experience, as someone who gets involved secondarily in the care of patients with infection, are often omitted or at least glossed over. And these are the microbiological history, the antibiotic exposure history, and the device history. And I don't know why these are glossed over, but they do tend to be, and I expect it's just because the relative importance of them may not be as clear to a generalist as a person with special experience in infection. So this is what I mean about these things. Why is it important to take a microbiological history when you're assessing a patient? The reason is that the treatment of infection, which I'll cover in much greater depth later, is based on a combination of things. It's based on a combination of antimicrobial therapy, the correction of any predisposing factors, if possible, and something which we generally refer to as source control, which I'll talk about in greater depth later. If a patient needs antibiotics immediately, the term used to describe the choice of antibiotic is empiric therapy, or best guess therapy. And empiric therapy is based on knowledge of a number of things, based on the site of infection, so the body site of infection, the types of organisms that would normally be expected to cause this type of infection, and the antimicrobial agent or combination that is most likely to cover these organisms. So if you know all of those things, you can then take a stab at empiric therapy. Now, as I'm sure you'll know very well, a lot of infections, urinary tract infections, intra-abdominal infections, skin and soft tissue to a large extent, a lot of infections are known as endogenous infections, and these are caused by a patient's own colonizing flora. And if a patient's microbiome contains multi-resistant organisms, then an endogenous infection is therefore more likely to be caused by multi-resistant organisms. Unfortunately, colonization with organisms, including multi-resistant organisms, is often very, very long-lasting, can even be lifelong. And empiric antibiotic regimens are based on the most likely causative organisms, which don't change, but unfortunately, they're also based on the most common patterns of antibiotic sensitivity. And this is an epidemiological decision rather than based on an individual. And if a patient is known to have an unusually resistant organism, perhaps from having previously had a urinary tract infection or intra-abdominal infection from which a multi-resistant organism has been isolated, then the standard empiric therapy, which would be used for all such patients, is less likely to work. So not taking the microbiological history into account carries the risk of treatment failure. So there's a clinical scenario here to illustrate this. All the scenarios in this talk are based on recent real-life cases. They're all changed subtly to disguise people, but they're based on recent real-life cases. I just need to move something on my screen so I can see it. So this scenario, 75-year-old woman presents to a primary care doctor with a 3-day history of redness and swelling, inflammation of the lower part of her right leg in an area surrounding a recent scratch. She's not unwell enough to require hospital admission. Now, during a recent hospital admission, MRSA was grown from a nose swab with no subsequent negative swabs. I should say at this stage that in where I work, MRSA, methicillin-resistant Staph aureus, is a relatively unusual thing to isolate. The vast majority of patients we deal with don't have MRSA, so we screen for it and take special account of it if we grow it. So whether that accords with local practice with you, I don't know. That's what we do. So the MRSA isolate from this woman's nose was reported as resistant to flucloxacillin and cotrimoxazole and sensitive to several antibiotics, including clindamycin, linezolid, and vancomycin. So resistant to flucloxacillin, cotrimoxazole, sensitive to clindamycin, linezolid, and vancomycin. So the question I've got, which will come up in a moment as a poll, is which oral antibiotic treatment would be most appropriate for this patient, assuming she has no specific contraindications to the suggested drug. Now, of course, you may think it's something else, but you have to choose the most appropriate or least inappropriate out of the following. So here's the poll. I'd be grateful if you'd all answer that. Of course, it's beautifully anonymous. I think I'll answer it myself as well. Oh no, it says host and panelists can't vote. Shame. I expect most people have voted now. I don't know how the audience response appears. Right, okay, so we have got which oral treatment would be most appropriate for this patient. Now, I'm not sure, sorry, I see the numbers are, the red one is the one which most people have voted for. Okay, well, that one was a bit of a trick question, as I think you'll know, you'll discover later. My preferred answer would in fact have been clindamycin, oral clindamycin, and I'll just go through the reasons for those answers. Flucloxacillin would be inappropriate because as we knew from the previous slide, I can't go back now, sorry. As we knew from the previous slide, the organism was resistant to flucloxacillin. Amoxicillin clavulanic acid is sometimes known as augmentin, and it's a beta-lactam antibiotic, and virtually all strains of MRSA, methicillin-resistant flucloxacillin, are resistant. So all the beta-lactams, except some very recent cephalosporins. So it will her organism, if she has cellulitis caused by the MRSA that was isolated from her nose, would be resistant to amoxicillin clavulanic acid. The organism was sensitive to clindamycin, and that was my preferred choice. Linezolid, I forget how many people suggested this. The organism's sensitive, but linezolid is a rather special antibiotic with quite an unpleasant range of side effects, and it should really be reserved for situations where there's no other alternatives. Vancomycin would be inappropriate because the question asked for oral antibiotics, and oral vancomycin is used only in certain luminal infections, such as Clostridium difficile infection. Oral vancomycin is not absorbed systemically, so it's no use for systemic antibiotic treatment. So my choice there would have been clindamycin, and this assumes that what we're doing is we're using the patient's recent microbiological history to determine what might be the cause of her current cellulitis. And I think that question probably shows how useful an exercise that is. So we'll go on to the next thing. The next aspect of the history, which is very important and often missed, is the antibiotic exposure history. So why is this important? It's important in my mind for two reasons. First of all, if a patient has an infection and they're already on antibiotics, and in other words, they've failed therapy, then they're unlikely to respond if the same antibiotic is continued or reused. And to some extent, to a large extent, this applies even if they've been treated orally and you're considering intravenous treatment. You wouldn't normally continue the same antibiotic. The other reason it's important is that if a patient has recently been given antibiotics, then they are more likely to have become colonized by organisms which are resistant to those antibiotics. It's not an on-off phenomenon by any means, but it's more likely that they'll be carrying strains of resistant organisms in their normal flora or their microbiome. So the empiric antibiotic choice needs to take both these factors into account. And again, just like the other thing I mentioned, failure to do this puts the patient at risk of treatment failure. I've got another clinical scenario here. This time it's a 71-year-old male who presents with fever, rigors, and clinical features to suggest pyelonephritis. This is a very, very sick person who's, let's say he's got septic and he's at risk of death. He's had several episodes of cystitis in the last 6 weeks. He has an underlying prostate problem, which have been treated in the community, initially with several courses of cefalexin, which is oral cefalexin, first-generation cephalosporin, but most recently with oral ciprofloxacin, a quinolone, which he just finished 2 days ago. There are no recent urine culture results, but 6 months ago, really before all this started, he grew an E. coli, which was quite resistant, and it was resistant to amoxicillin, clavulanic acid, cotrimoxazole, and gentamicin, but sensitive to cefuroxime and ciprofloxacin. It's quite difficult to remember what's on this slide, I know, when we move on to the next one, but try and remember it was resistant. It was sensitive to, it was isolated 6 months ago, and it was sensitive to cefuroxime, sensitive to ciprofloxacin. So the question here, we have which of the following antibiotic options, now there's no trick here, some are oral and some are IV, would be most appropriate for this patient, assuming no specific contraindications. So hopefully the question, there we are, take your pick. I should say while you're voting, it's probably a really important point that I made earlier, which is that antibiotic choices are very much a local matter for local epidemiology, and therefore the choices that I make in my practice may not accord with what you would do in your practice. So let's see the answers. So the favorite choice here is cefuroxime 1.5 grams 8 hourly. The second favorite was ciprofloxacin. So I think that's quite interesting. Now, local practice, and as I say, it's local, would actually be to give this patient meropenem. And I'll just explain why, because it's obviously not what anyone, well, not what many people thought was correct, and I wouldn't pretend it is correct. It would just be local practice where I work. So amoxicillin would be inappropriate. So the first things first, this patient is septic, old, very sick, needs to get the right antibiotic immediately, because if they don't get the right antibiotic, then there's a high chance of treatment failure and death. So it's very important that the antibiotic this patient gets immediately covers the cause of this pyelonephritis. Amoxicillin would be inappropriate because the organism was resistant. The organism he had 6 months ago was resistant. And I think it's a really important point that he had this organism 6 months ago. It may or may not be relevant to his current infection, but from experience, it's determined that it's very important to take into account the organisms the patients had, even if it's quite a long time ago, because as I said in the previous section, they tend to carry them for a long time. So it wouldn't be appropriate to give amoxicillin because that organism was resistant. Similarly for cotrimoxazole, it was resistant. Cefuroxime is a very interesting one. The organism he isolated 6 months ago was actually sensitive to cefuroxime, so I can see why it would seem a reasonable choice. And I'm sure for some people it is a reasonable choice. The only thing I would say is that this patient has had a lot of exposure recently to cefalexin. Cefalexin is a cephalosporin. It's not the same generation as cephalosporin, but the potential generation of cephalosporin-resistant organisms is quite likely in this patient. So personally, I would avoid using cephalosporins until we confirm the organism is sensitive. Gentamicin, I think the organism was resistant to. Ciprofloxacin, now the organism he had all those months ago was sensitive to ciprofloxacin, but unfortunately I said that this patient has just recently effectively had treatment failure with ciprofloxacin. It was only 2 days ago he stopped it and he's now septic, so it wouldn't be appropriate to use ciprofloxacin. So my practice here would be to use meropenem to start with, hoping that we get either a urine isolate or blood culture isolate very quickly, which would enable us to narrow down our antibiotics to use a less broad spectrum antibiotic. So the third aspect of history, which I think is particularly important and often skimmed over, is the device history. So treatment of infection, as I said, is based on antimicrobial therapy, correction of predisposing factors, and source control. Device-related infections are caused by a very specific range of organisms. They're usually organisms that have to be able to stick to metal and plastic devices. And furthermore, they're less likely to respond to antibiotics in the absence of source control. And again, just through experience, examples of devices which are easily overlooked in history taking for patients with infection are, perhaps surprisingly, something as obvious as a pacemaker. And that's because once a patient's got a pacemaker, they have it for many years, and the patient may well forget they've got it, not mention it in a history. It's possible it might be skimmed over by the person asking them a history as well. Prosthetic joints, again, if they've been there many years, they're often overlooked. Arterial grafts, they also last a long time and can be forgotten about. Ureteric stents, tunneled lines. It's even tunneled lines for patients recently had cancer chemotherapy. They can be overlooked if the person taking the history doesn't appreciate the potential importance of them. So it's just really an important point, taking a device history. I'm not going to go into any details about physical examination because, of course, the examination is determined by the type of infection you're dealing with, which is determined largely by the history. And then the investigations are determined by a combination of history and examination findings. So clearly a comprehensive history, including those 3 factors I mentioned, has to underpin everything else. Once you've taken your history and examined the patient, then of course you'll do a number of investigations, and the investigations, like the history, are aimed at determining both the presence of infection, usually done with biochemical markers of infection, and also the site of infection. And there are many ways of doing that, but and I think imaging tests are very large on that list, but I'm just going to concentrate on microbiological investigations for now. Now, it may help if you're thinking about what microbiological investigations to do in a patient, it may help to divide them up into these 3 modalities. This is how I think of investigations in my mind. So there are direct detection tests, there are culture tests, and then there's serology or immunological tests. Now, unfortunately, sometimes people refer to antigen detection tests as serology tests, whether they're done in blood or other fluids. So it's not a completely fail-safe categorization, but that's how I remember microbiological tests. And these types of tests have different roles and are used at different stages of infection. So by direct detection tests, I mean things that you can do which will tell you very quickly whether a patient has an infection and often where it is. So things like microscopy, CSF microscopy, sputum microscopy for AFBs, urine antigen tests for Legionella, pneumococcal disease, blood antigen tests for Cryptococcus and so on, and PCR tests for nucleic acid from microorganisms. So these tests give a result early in infection. They may confirm the location of infection, but they rarely give specific information on antimicrobial sensitivities. So they're useful to give you an idea of what's probably causing the infection. Culture is still very, very widely used, despite being a very old and well-tried set of tests. Culture may confirm the location of the infection if it's not something like blood culture, which is sort of secondary, but it unfortunately gives a delayed result inevitably. However, it is very important because it's a prelude to most sensitivity testing, especially bacterial and fungal sensitivity testing. And then serology and immunological tests give a result late in the course of infection. That's fine if the infection you're dealing with is one where it doesn't matter whether you pick it up early or late in terms of treating a patient. But for many infections, serology is a bit late to make an acute diagnosis, but it's still useful for epidemiological purposes. Just a final note on diagnosis here. Okay, I don't know where I read this, but I read someone's summary here who said, hold your diagnosis lightly. And I think it's a really, really important point, especially in acute medicine. So I'm involved in Davidson's, and of course Davidson's is a medical textbook, which tends to concentrate on characteristic patterns of disease. But it's a really important point that patients rarely walk straight out of textbooks, especially in acute medicine. And a diagnosis is only ever a working hypothesis, and it has to be constantly reviewed and refined. And just a very, very common example of shifting diagnosis, which I come across very frequently in my practice, which largely involves elderly people. An elderly patient presents acutely with fever, breathlessness, delirium, and abnormal breath sounds, unspecified. The working diagnosis in that situation is likely to be community-acquired pneumonia, perhaps with an element of heart failure, COPD, or something else. But likely, in the differential list at the top, is likely to be community-acquired pneumonia. It's not uncommon to then grow an organism from a patient's blood cultures, which turns out to be an E. coli or a gram-negative bacillus of some other sort. And at that stage, the diagnosis and treatment, the diagnosis needs to be revised, reconsidered, and refined, and probably so does the treatment. The reason being that although this fits with pneumonia, an E. coli grown from blood culture rarely fits with pneumonia. It fits with aspiration pneumonia, and it fits with hospital-acquired pneumonia, but it rarely fits with community-acquired pneumonia. And it's more likely that the patient actually has some undiagnosed urine infection or intraabdominal infection. So hold the diagnosis lightly. It's a really important point. Now, I'm just going to briefly go over some features of the principles of clinical management of infection. So the clinical management of infection essentially has four components. First of all, resuscitate and treat sepsis, give antimicrobials or antibiotics, address any predisposing factors, and establish source control. But these have riders. They're all conditional. Resuscitate and treat sepsis if present. Give antimicrobials, antibiotics if necessary. And it's a really important point that it's not always necessary. Address predisposing factors if possible. Unfortunately, it's rare to be able to assess predisposing factors unless they are devices, in which case establish source control if possible. And I'm really just going to mention giving antimicrobials and establishing source control. Using antibiotics, I've got this grand scheme for using antibiotics here, which I think is really important to hold in your mind whenever you're selecting antibiotics in a patient who you think has an infection. The first point at which you make a decision is when you have taken a history and examined the patient and made a clinical diagnosis. And really what you're likely to know at that stage is the organ system involved. And that's the stage where you start empiric therapy, which I've mentioned several times already. And it's based on your knowledge of things. But actually, certainly in my practice in the UK, I don't know the extent to which this is the case where you work, but it's also based largely on antibiotic policies, which are guidelines written by local experts in infection who take these things into account for you. The next stage you have is where you've got the results of some laboratory investigations, perhaps some direct detection tests, perhaps early culture results. And at that stage, when you think you know the actual organism that's causing the patient's infection, you're able to target your therapy to some extent based on the identified pathogens. So if you've treated a patient with very broad spectrum therapy that covers fungi, gram-positives and gram-negatives, and you've now concluded that the patient's got a gram-negative infection, then you can start to target your therapy by removing the fungal and gram-positive components of the antibiotic treatment. And then the final stage where we hope to find ourselves at is sensitivity-guided therapy, which is based on all the microbiology results, including antibiotic susceptibility results. So there's a very important couple of arrows here. Basically, as the information about the patient or about the patient's infection increases, the antibiotic spectrum or antimicrobial spectrum that's being used in that patient should decrease. And it should be an active process of reducing the spectrum of antibiotics wherever possible. In the UK, this has been summarized as start smart, then focus by the Department of Health. And it's the reason why you have to constantly revise and review diagnosis and treatment in the early stages of a patient presenting with infection. Start smart, then focus. And a very important point about this is that microbiology results actually override empiric therapy. That may be obvious from the picture I showed on the previous slide. what we find in the UK is that the antibiotic guidelines are used very, very well by and large, because there are various initiatives put in place to make sure they're used. Every now and again, though, guidelines people use guidelines inappropriately, because they're only designed for empiric therapy. And once you have something to base targeted therapy on, you then move towards the microbiology results as your source of information rather than the guidelines. And I have seen situations where patients have been treated empirically even when they have microbiology results to go on. So that in terms of giving antibiotics, this is all about choosing all I've been saying up to now is about choosing antibiotics, but the really important point is you only give antibiotics if necessary. And the thing you should have at the top of your mind before you prescribe an antibiotics is that all antibiotic use is hazardous. And it's necessary only if the risks of not treating the patient outweigh the risks of treating the patient. And of course, there are a lot of risks associated with treating a patient with antibiotics. First of all, the risks associated with any drug, allergy and general adverse effects to a drug. But then there are the risks of predisposing them to one of the conditions which is associated with antibiotic use. In the UK, Clostridium difficile infection is reasonably common. And then there is the general risk to the population of increasing the chance of antibiotic resistance developing not only in that patient but in other patients if resistant organisms are transmitted to other patients. And it's important that antibiotics are not necessary in self-limiting or non-bacterial infections. And they're not needed acutely in non-severe infections that haven't yet been fully diagnosed, so a sort of PUO situation where a patient isn't particularly ill, and also in serious but indolent infections where there's not yet a microbiological diagnosis, because in those situations, like prosthetic joint infections and so on, the main priority is to get a microbiological diagnosis so you can ensure that you can target the treatment appropriately and use the narrow spectrum antimicrobials that you can. So before you prescribe an antibiotic, you've got to ask yourself, is it really necessary? But of course, if a patient's septic, it's always necessary. Here we have the third clinical scenario to try and illustrate this. This is a 75-year-old woman who presents with a 4-week history of gradually increasing low back pain. So 4 weeks. 2 weeks ago, she had cystitis caused by a multi-resistant Enterobacter cloacae, which was treated successfully with trimethoprim. On examination, she is febrile, she's tender over her lumbar spine and paraspinal muscles. There's nothing else. And her blood tests suggest she has some infection or inflammation. Now, they select some sensitivities from her urine isolate, which preceded all of this, were that it was sensitive to trimethoprim, ciprofloxacin, meropenem, resistant to amoxicillin, clavulanic acid, cefuroxime, and gentamicin. So the question I have for you in this patient who, let's face it, has probably got spinal epidural abscess or discitis or something, is what do we do at this stage? And here are some options. Oh yes, I forgot to say, she's been in hospital for a day and a blood culture taken at admission has grown gram-positive cocci in clusters, so likely staphylococcus. A urine culture is being processed and she's awaiting an MRI of her spine. What would be the most appropriate action at this stage? Start oral trimethoprim, start intravenous flucloxacillin, start intravenous meropenem, start intravenous vancomycin, or none of the above. There you are. It's very encouraging when the poll comes up, because I'm sitting here in a room with no feedback, thinking I'm talking to a white screen. But when the poll comes up, I realize that at least someone's able to hear me. It's very encouraging. Right, well, so the top answer is, of course, none of the above. And I'm very impressed with that, not least because you're all medical students. So you all know that where there's a multiple choice question and one of the options is none of the above, it's usually right, but not always. So, but actually your suggestions are quite broad. Now, what I would do, personally, none of the above. And the reason for that is that this woman probably has discitis. Discitis may be caused it may be secondary to urinary tract infection. Sometimes you get discitis caused by the same organism as caused a recent UTI, but it may not. And in fact, in our experience locally, it's usually caused by Staph aureus. We've got a gram-positive coccus in a blood culture, but at the moment we've got no idea what that is or whether it's relevant. It might turn out to be a coagulase negative staph, which is unlikely to be the cause in someone if they haven't got any devices in their spine. So we don't really know what's going on. And very importantly, this patient is stable and she's been ill for at least 4 weeks. So really, this is a classic case where there's no need to rush in and do anything. So I wouldn't personally do any of these things, and my none of the above would basically be to wait for the MRI scan, wait to see what the gram-positive coccus is. If it's a Staph aureus, then I think we've probably got our microbiological diagnosis. And also the MRI, critically, the MRI scan may give some option for sampling by aspiration or biopsy, which would give us the definitive microbiological diagnosis. So you don't need to rush in and start patients on antibiotics every time. Source control, this is where I finish when I'm talking about management. So antibiotic treatment has limitations. It has very limited penetration into collections or abscesses and very limited effect on biofilms. So ideally, the primary site of secondary infection, like a bloodstream infection, should be identified and removed. Now I say ideally because it's really a matter of negotiation and balances of risks. Source control is therefore as important a thing to consider as antibiotic therapy. And there are many, many examples of what I mean by source control, drainage of abscesses, any collection of pus anywhere, joint washouts, debridement of necrotic tissue. I think most people accept that necrotizing fasciitis is unlikely to get better unless there's some debridement, as well as antimicrobial therapy. Removal of intravascular devices, often impossible, but it's something that needs to be considered at the very least. Removal of other intraluminal devices, ureteric stents, very important to eradicate a urinary tract infection in a patient with a ureteric stent, biliary stent, and removal of extravascular devices like prosthetic joints, pacing devices. As I say, it's really important to remember that these often cannot be removed, but the ideal situation, just in terms of getting rid of the infection, is that they should be removed. So it is at the very least something to consider every time you're faced with a patient with an infection. So I've got 2 cases here which are based on relatively recent real life situations, and I chose them because I hope that they illustrate some of the points that I've made up till now. And the first case, they're actually based on information that's available through hospital computer systems and discussing with doctors. They're not based on a forensic scrutinization of the patient's notes. So the first case is a 26-year-old woman who is on long-term total parenteral nutrition via a portacath, which is a indwelling reservoir venous access device, because she has a chronic small bowel absorption problem, which isn't going to go away. She presented to A&E, or the emergency department, with a 3-day history of worsening low back pain, which radiated to both her hips. Today, she has developed vomiting and central abdominal pain, so quite a few symptoms. She's got no other symptoms, and specifically, she's got no diarrhea or urine symptoms, which might help to establish what the cause or source of her abdominal pain is. On examination at admission, she was sweaty and pale, but she was afebrile. Her heart rate and blood pressure were moderately abnormal, respiratory rate normal, SATs 96% on air. The only abnormal examination findings which are reported were bilateral flank tenderness, which was worse on her right side. The portacath site wasn't actually documented or mentioned in her ED A&E records. Later, it was determined that there was no inflammation at the site of the portacath. She didn't have urine dipstick testing done. I haven't mentioned urine dipstick testing up till now. It's often done and it should really be done in people who are thought probably to have a urinary tract infection. If it's done in people who aren't thought to have a urinary tract infection, it doesn't usually give any useful information about infection. It might give you information about hematuria and protein and so on. So urine dipstick testing wasn't done. Whether that's because there was no urine available or because it was forgotten, I don't know. She had some blood tests which showed she was mildly anemic. There was no raised white count and no raised C-reactive protein. Bilirubin was slightly high and her alkaline phosphatase was slightly high. The A&E diagnosis, there was no differential diagnosis list in this case. The A&E diagnosis was query pyelonephritis, but then in brackets it said unclear source. So I think what that probably means is number 1 is pyelonephritis, number 2 is some other source of infection, which I, the admitting doctor, haven't established. We can just stop there for a moment and think about the things in her history which would make you think she's got pyelonephritis and the things in her history which wouldn't or might not. Firstly, I think she does have back pain. Low back pain is consistent with a urinary tract infection. She then has developed vomiting, which is consistent with septic presentations and infection generally, and central abdominal pain. And then when she was examined, she had flank tenderness worse on one side than the other. So there are some features to suggest pyelonephritis. There are some features which aren't really consistent with it. For instance, the absence of a raised white count, although that can be normal, of course, and importantly, the absence of a C-reactive protein. I think in most patients who have got established pyelonephritis, it's usually started as an ascending urinary tract infection, and by the time they've got pyelonephritis, you'd expect them to have a raised C-reactive protein. Her liver function tests are mildly elevated, but that can be a non-specific finding. So it's not a sort of obvious diagnosis. So the patient was admitted. She had peripheral blood cultures sent. She was started on intravenous amoxicillin, gentamicin, and metronidazole. And this was chosen because it's the empiric choice for patients with what's described as sepsis of unknown source. I don't think this patient can be said to be septic, but she has an infection of an unknown source. So although the admitting doctors put this at the top of the list, actually the choice of antibiotics is broad, and that is empiric therapy, just classically as I've described it earlier. The next day, the patient's blood culture grew gram-negative bacilli in one bottle, anaerobic bottle. Her urine was negative for white cells and was being cultured, and her antibiotics had been stopped. I was peripherally involved in the case at that stage. Her antibiotics had been stopped. It was never completely clear why. I think it was because she seemed to be quite well. However, she had recently spiked her temperature now up to 38 degrees. At this stage, there was a clinical discussion. Because we've grown a gram-negative bacillus in a blood culture bottle, it was advised to reassess the patient for possible sources of gram-negative bacilli, arrange for CT of her abdomen, pelvis, and MRI spine if the CT was non-diagnostic. So you can see that this illustrates a medical setting where these tests are easily available. There was advice to repeat the blood cultures, but this time taking into account the presence of an indwelling device and asking for paired peripheral and portocath blood cultures. Paired cultures can often help you determine whether there's a line infection. It was also noted that she did have a history of a multi-resistant Enterobacter cloacae from about 8 months previously. And the advice here was start the patient on meropenem. She'd spiked. She had a multi-resistant organism in the past. It seemed reasonable. Then what happened the next day was the blood cultures from the portocath lumen, both bottles, grew gram-negative bacilli, but the peripheral blood cultures taken at the same time remained negative. So that finding would suggest that there were a lot more bugs in the portocath lumen than there were in the peripheral blood when the samples were taken, as long as the volumes were roughly the same. And it's kind of consistent with or suggestive of a portocath infection. The blood culture isolate from the first day, peripheral, was identified as Enterobacter cloacae. A urine culture was negative, and all the scans I mentioned were negative, non-diagnostic. Patient was well. So the most likely diagnosis at this stage becomes a luminal portocath infection, and this is a diagnosis of exclusion. So really, most of the other possibilities based on back pain, abdominal pain, and so on, have been excluded really by that imaging, and the paired blood culture results suggest a device-related infection. So I mentioned earlier holding the diagnosis lightly, and I think this is, I think I'll be talking about that later actually. So treatment options at this stage, once that diagnosis is accepted, bearing in mind that it's only ever a working diagnosis, are systemic antibiotics, line locks, and or line removal, which would be the ultimate method of source control. In this case, this would be a significant intervention, and it wasn't considered to be possible on a balance of risks. And the patient was treated with an attempt at line salvage, treated with intravenous meropenem, which was then changed to oral ciprofloxacin, and gentamicin line locks. The Enterobacter was sensitive to gentamicin. So the question is, what does this case illustrate from the talk? And I think it illustrates the importance of a history, including microbiological history and device history. She did have a multi-resistant Enterobacter, which would have to be taken into account if she needed treatment. And she did have a device which was kind of glossed over a little bit, but was very important in her assessment. Demonstrates a transition from empiric to targeted antibiotic therapy, which overrides empiric therapy. Ideally, in that situation, you transition from a broad spectrum antibiotic or combination to a narrow spectrum antibiotic. Unfortunately, in this case, the transition was the other way. Really, meropenem, where we work, is a very, very broad spectrum antibiotic. It illustrates to some extent the challenge of multi-resistant organisms, and unfortunately, the situation is that where you know a patient has had a multi-resistant organism in the past, until you've determined the cause of their current infection, you have to use a broader spectrum of antimicrobials than you otherwise would. And so unfortunately, multi-resistance breeds multi-resistance, because using those broad spectrum antibiotics predisposes to the development of more resistance. It illustrates this holding the need to hold the diagnosis lightly. The early information suggested pyelonephritis as a possibility. Urine culture and CT abdomen were negative. Paired blood culture suggested an alternative diagnosis, and it illustrates the challenges of source control. So I said earlier that ideally, source control involves removing the primary source of an infection, but this was a situation where that wasn't possible. So I got one more case. This is very, very brief. And this is an 84-year-old woman who presented with a 6-week history of increasing lethargy, shortness of breath, and weight loss. She had no symptoms that related to any specific body system, or at least none were available from the records. Her past medical history was very important and included a metallic mitral valve replacement with current aortic stenosis and tricuspid regurgitation. There was no relevant microbiological history, but in terms of treatment history, this patient was given a week of oral amoxicillin by their primary care doctor, or family doctor, a few weeks ago, which caused no improvement in any of her symptoms. Now, this is something that we find to be quite common, is someone who presents with an evidence of an indolent infection. If you look into the recent history, you'll often find that they presented to their GP or family doctor one or a number of times during that period, and often rather sort of vague attempts have been made to treat the patient. But I think that would really be an example of where, if a patient has an indolent infection, it's much better to try and make the diagnosis and get a microbiological answer than to just treat on spec. But sometimes, of course, it's appropriate. She had a temperature of 37.8, and there were no abnormal examination findings at all, other than the expected heart murmurs. She was found to be anemic. Her white count wasn't raised, but her CRP was 176, which is raised. She had a very mildly raised bilirubin, alkaline phosphatase was raised. Her chest X-ray showed sternotomy wires. Her valve ring was visible, and also a pacemaker system, which wasn't mentioned in the history. She had an ultrasound of her upper abdomen, which was done on the basis that her liver function tests were a little bit abnormal, and she probably had an infection, but it showed no abnormalities. And she had multiple blood cultures done when she came in, and quite quickly 3 pairs of these grew gram-positive cocci in pairs and chains, and these were subsequently identified as Enterococcus faecalis. So the working diagnosis, which in fact right from the start had been infective endocarditis, at that stage became much more clearly prosthetic valve endocarditis with an organism. And at the time I put this together, she was still awaiting an echocardiogram. She was started on intravenous amoxicillin and gentamicin as soon as sensitivities were available. And the aim with this person will be to treat her with antibiotics alone, which will require a prolonged period of antibiotic therapy. And the echo is important. You might ask the question, why bother when we've made the diagnosis by other means? But the echo is very important. First of all, it may help to confirm that the diagnosis is correct. But secondly, it may be useful to determine staging and the possible need for surgical intervention. So I think that's it's not an uncommon scenario actually where I work, but I think this case illustrates the importance of a good history, again, including a device history. Now, I don't think that many people, when they're taking a history, would manage to overlook the fact that a patient had a valve replacement at some time in the past. Easy to overlook the fact they've had a pacemaker, although it usually becomes apparent later. But if she had just said if she had just had some aortic stenosis or other valve condition, it could have been overlooked. I think it's important here, there's no urgency to start antibiotics until the microbiological cause is known. So again, this is a case where she'd been ill for at least 6 weeks by the time she was assessed and the blood cultures were taken. And the priority here is to work out the microbiological cause, because what sometimes happens in situations like this is the patient is started on very, very broad spectrum antibiotics at the same time or even before the microbiological investigations are done, in this case blood cultures. And the problem with that is the broad spectrum antibiotics will tend to kill the organisms that cause the infection, whatever they are. So when it comes to trying to narrow down the antibiotic from the very broad spectrum antibiotic combination, it becomes impossible. And that can be a particular problem. Endocarditis is generally treated with intravenous antibiotics in our practice throughout, but in a lot of infections, there's a change from empiric intravenous to targeted oral antibiotics. And unfortunately, if you haven't managed to determine the microbiological cause of the infection, choosing the targeted oral antibiotics, which what allows the patient to go home from hospital often, can be very, very difficult or impossible. And it also illustrates the challenges of source control. Now, from the pure point of view of eradicating the infection, removing the heart valve would be definitive. But that's a major intervention, cardiac surgery, and I think she was an 84-year-old. So clearly that's not going to be done except in very special circumstances. And so this is a situation where source control isn't achieved, and instead of that, a long course of the most bactericidal antibiotics that can be selected would be used. So this is what I have tried to do during this presentation. Hopefully, I have helped to illustrate the vital importance of a good history, including these specific aspects of history which are very important for infections but often overlooked: microbiology history, antibiotic history, especially if there's a history of multi-resistant organisms, and device history. The need to keep the diagnosis and treatment under constant review because it often changes as new evidence and information becomes available. When to use and when not to use antibiotics. Bear in mind that all antibiotic use is potentially hazardous, so don't use antibiotics unless it's very important. How to choose and refine antibiotics, and what I really want you to remember as a take-home message is those two big orange arrows. The information arrow, which got fatter as it got to the bottom of the screen, and the antibiotic spectrum arrow, which got narrower as it got to the bottom of the screen. and the importance of source control and also the difficulty of source control. I did also manage to give you a 50-minute talk without mentioning COVID once, which I found quite refreshing when I was putting it together. So that's the end of my presentation, and I now have question and answers, which I'm going to look at on my screen. Take a moment, take a breather for a moment whilst I just look at the question and answers. Right, the questions are, I'm just going to select ones which I think might illustrate some of the important points that I've covered. I hope so anyway. I don't know what happens if I click on answer live, but I'm going to start with, you would like to answer, so what, yes, sorry, done. So the question is, can you tell appropriate antibiotics for oral infections? Sorry, I'm not sure. I think I just read it out, I think. So can you tell appropriate antibiotics for oral infections? I think that's a very broad question, and I think the important point is not to talk about any specifics for oral infections, but to say that when you're choosing antibiotics in a patient, you should try and change from intravenous to oral infections as early as is clinically safe, because the continuing presence of intravenous access can often be avoided, and that itself is a risk to infection. And also, of course, it's much more convenient to the patient. And the choice of oral antibiotic should follow the same principle as I mentioned before, which was start smart, then focus. So it should be the narrowest spectrum available. Unfortunately, with oral antibiotics, you have to, and with any antibiotics, you have to take into account all the potential hazards of the antibiotic. So in my practice where I work, because it's elderly people, we're in the UK, one of the main hazards is the development of Clostridium difficile infection. So we try and avoid using oral quinolones and cephalosporins where we possibly can. There's a question, we've studied that for MRSA choice is vancomycin, and if that's also resistant, linezolid. Yes, I think that's a really good point. So if you go back to the question where I asked about the woman with cellulitis, the options I gave, the question I asked was which would be the most appropriate out of the options given, and the options given were all oral options, and one of them was vancomycin. And of course, as I explained, oral vancomycin wouldn't be an appropriate treatment for a patient with an infection that needs systemic antibiotics because it's not absorbed. Now the patient the patient had a mild infection. She had cellulitis that was probably going to respond to oral antibiotics. And the person has suggested that linezolid would have been an appropriate treatment. And I agree, the organism was sensitive to linezolid, but the reason I chose clindamycin and not linezolid was because in our local practice, we try and avoid using linezolid because we find it has unfortunate side effects, and we also try and reserve it for situations when it's absolutely needed. So it's a very good point, but that was the reason for my choice. There are lots of questions, goodness me. There's a rather long one here. Let me see. Sir, in case of fungal infection, suppose we start empirical antifungal and sample for fungal culture sent before starting this antifungal, but fungal culture takes more than a month. Hence, can there be a delay in starting appropriate antifungal? I think this too has to follow the same principles. So fungal infection can mean many things, from a superficial infection, candidiasis, or perhaps a dermatophyte infection of tinea pedis or something like that, right up to a systemic fungal, a serious fungal infection such as invasive aspergillosis, which of course is rapidly life-threatening. And so really the same principles would be applied to fungal infections as would be applied to bacterial infections, bearing in mind that culture might take quite a long time. Now, I would hope that fungal culture wouldn't normally take as long as a month, but I appreciate that some fungi are very slow growing. So for example, looking at those two ends of the spectrum, if the patient has invasive pulmonary aspergillosis or clinically has invasive pulmonary aspergillosis, then they do need empiric fungal infection very quickly, and they need a very broad spectrum antifungal. And there are various options which are used in different places for that. But if the fungal infection that's being treated is a superficial fungal infection of their toe or of their skin, then there's no urgency in treating. And even if it does take a month to get a result, there's no problem in waiting for a month before starting that antifungal agent. So really it's a matter of applying the same principles, but to various different situations. Let me see, I think I've explained about clindamycin, and I know I've made the point before, but I have to say that the choices I've made are the choices we would make where I practice, and I wouldn't pretend that they're correct or incorrect. Can you, right, here we go. This is a good question. As laboratory diagnosis of infection is often time-consuming, we as doctors prescribe antibiotics based on clinical diagnosis. How do we ensure that we give targeted therapy of antibiotics when we're stuck in between many differential diagnoses? So, sorry, I'm just trying to find where my mouse is. Well, I think that is really fundamentally the question that I've tried to cover. You're stuck in between many potential differential diagnoses. So the most important thing there is to, first of all, target your history very carefully to make sure that you have as few differential diagnoses as possible. And then, even if you have got a large number of differential diagnoses, you have to start by using empiric therapy, which covers all of them. And then as information gradually becomes available, you can hopefully narrow that down. And often a patient presents septic with no clues as to what might be causing their infection. They need antibiotics, and they need antibiotics very, very quickly. So we in our hospitals would have an antibiotic guideline or policy that says this is what you give for patients who've got sepsis of unknown source. And there'll be alternatives depending on allergies and so on. But essentially, that's what you have to start. And it's a really important point that you do have to start broad spectrum antibiotics empirically. But of course, the key is then to target them down. It's to take whatever samples you can, do whatever investigations you can, and then target the antibiotics as much as you can later. So some of these are very broad and difficult to answer. Some of them I think I probably have answered, perhaps they were asked earlier on. Here's a great question. How do antibiotics affect the normal flora? Well, I don't think it's possible to summarize how they affect the normal flora, but I think it's fair to say they do affect the normal flora. And yes, I suppose the summary would be that as far as we know, the way in which antibiotics affect the normal flora is that they enhance the development of antibiotic resistance by selection pressure on to select out resistant organisms. And that is the whole point of the issue about treatment history being so important. I think I'll probably answer one more question because I think I've probably had my time now. Let me choose a question here. Okay. Sorry, are we supposed to, no, are we supposed to give, no, I'm not going to answer a question about COVID-19. It's not fair. I'm trying to avoid COVID-19. I'll just choose this one. Antibiotics are damaging natural flora of body, can we replace antibiotics with other sort of medicine? Well, that's extremely difficult. There are certain situations now where other sorts of medicine are recommended over antibiotics. I think I would need to check this to confirm, but I think local guidance on the treatment of impetigo is for non-antibiotic compounds, from memory acetic acid or something like that. But certainly wherever the first thing said is rare for there to be alternatives that are non-antibiotic for the treatment of bacterial infections, but clearly where there are, then they shouldn't be used. And I think the most important thing to say is that if the alternative is no treatment, then no treatment should be used. So I think there are, I've answered a few. There are 100, there are 150 questions or something, which I can't answer now. But I've answered a few of the questions, and hopefully I've answered them consistently with what I said in my talk. And I very much hope that you have enjoyed the talk. And I think I'll stop now. Thank you very much.
Thank you, Dr. Richard. Yes, we have more than 100 questions now, and I know it is not practically possible to address them all. So we will try to share the answers for these over the email with the participants. Hope that is okay with you. We can share the questions with you and we can reply them, whichever the important ones, and we can reply them over the email with their queries.
Well, you can certainly share them.
Yeah.
I'll see what I can do. 100
Okay.
questions might be beyond my capacity to answer at the moment, but thank you.
Yeah, thank you so much for the talk. I'm sure the students will get a lot of benefits out of it, and it will surely help them in their coming exams and all here. Just to close the things, I would like to say that we will be sharing the recording and the certificates for this session over the email in next 7 to 10 working days with everybody. Any other parting notes, Dr. Richard, for the students?
No, I don't think so. I think I've tried to make it clear that this is about principles rather than specifics, and that's probably the most important point.
Thank you. Thank you so much for joining us today, and thank you everyone for joining us. Thank you. Thank you so much.